Welcome to Steady Balance on Spotify, your space to understand the science behind balance and vertigo.
Hello, everybody. This is Dr. Arjun Singh. I'm an MBBS MS in ENT. I'm an ENT surgeon. I have a setup at Kapurthala Hospital and Nursing Home, and I'm a consultant ENT surgeon at Dr. Shangara Singh Hospital in Jalandhar City in Punjab. Today, I'll be discussing and busting some common myths about vertigo. So, we have covered a lot in this series, but even after people finally get a diagnosis, many carrying beliefs about vertigo that simply aren't true. And those myths matter. They delay treatment, they discourage recovery, and they make an already difficult case and experience even harder. So, today, for our final episode, we'll be cleaning the air. The most common myths and what the evidence says actually. Welcome to Steady Balance. This is episode 16. So let's start with one of the biggest misconceptions, that is, vertigo is not same as general dizziness. In medical terms, vertigo basically means a false sensation of movement, usually spinning, tilting, or shifting when you are actually still. So, why does it matter? Because how you describe your symptoms shapes the diagnosis by the doctor. Saying I feel dizzy is very vague, but saying I feel spinning when I roll over in the bed can immediately point towards BPPV, the most common vestibular cause of vertigo. So, another common myth is that vertigo is fear of heights. It isn't. Fear of heights is called acrophobia. It's actually a psychological response. It's a functional disorder. It's not a physical disorder. It's not same as vertigo. Vertigo, on the other hand, is a medical symptom related to balance system dysfunction. Confusion comes for everyday language, but medically, these are completely different things. This is one of the most harmful myths, that there is no treatment. You just live with it because it stops people from seeking help. The truth in many forms of vertigo is treatable. For example, BPPV is often treated with repositioning maneuvers like Eppele's maneuver. Vestibular rehabilitation has a strong evidence for improving balance and reducing symptoms. Vestibular migraine can be diagnosed and managed with the targeted treatment. Even conditions like Meniere's disease, which are not curable but are still manageable, both medically and surgically, endosympathetic sac decompression and medication and exercises help in all the above conditions. So the real issue isn't that nothing can be done. It's that the right diagnosis leads to the right treatment. So when vertigo hits, resting feels natural, and during severe episodes, it can help. But long-term bed rest, I don't think it's a good idea. It can actually slow down the recovery. The brain adapts to the vestibular problems through movements and recalibration. Avoiding a movement for too long prevents this adaptation. That's why vestibular rehabilitation works. It uses controlled, gradual movement to retrain the brain. And in some cases, prolonged avoidance can contribute to conditions like PPPD. So dizziness persists due to heightened sensitivity and behavioral patterns. Another myth regarding vertigo is seriously wrong with the brain. This fear is very common and understandable, but there's a reality. Most vertigo is peripheral and not central, meaning comes from the inner ear and not the brain. Conditions like BPPV, Meniere's disease, vestibular neuritis can feel severe, but they are not actually life threatening. Yes, central causes like stroke do exist, but they are far less common. The key is not to assume the worst, but get a proper evaluation with proper history and a proper discussion with ENT surgeon. Another frustrating myth for patients, which states if the tests are normal, nothing is wrong. So normal tests do not always mean that there is no problem. Usually odometry is fine and MRI brain is fine. That does not mean that there is no problem. Some vestibular conditions are diagnosed clinically and there are no tests as such that we have physical tests diagnose vertigo exactly. So some vestibular conditions are diagnosed clinically, especially when the symptoms come and go. For example, vestibular migraine, PPPD, episodic conditions like BPPV or Meniere's disease. These may all show normal test results between the episodes, lucid interval, when symptomatically okay, and any tests we do during those times would come out to be normal. It does not mean that problem isn't there. So if your symptoms are real and persistent, normal tests are just one part of the picture, not the final answer. So let's close the series with three key takeaways. One, learn to describe your symptoms clearly in good language leads to better diagnosis. Key number two, takeaway key, treatment exists for many vestibular conditions, but it starts with the right diagnosis. Number three, recovery is possible with the right approach. Most people can see meaningful improvement in the quality of life.
A public awareness initiative by Dr. Reddy's. This communication does not substitute advice of a medical practitioner. Please consult your doctor for any medical advice.